Welcome back to Core EM. I'm Brian Gilberti, and today we're joined by Dr. Sadakat Chowdhury, who's quickly becoming something of a regular here on the show. Now, Sadakat did a fantastic episode on ARDS a couple of months ago. He's also featured on our YouTube channel with an essential segment on the primary trauma survey. And today he's back to talk about an oncologic emergency that every emergency doctor has to recognize and manage, which is blast crisis. So, Sadakat, thanks for being back in the studio with us.
It's really nice to be back, Brian, and thanks for the plug. Everyone go check out the ARDS podcast and the video segment, but I'm very excited to be back at Core EM.
We're thrilled to have you back, Sadakat. So let's kick things off with the basics. What is blast crisis, and why is it crucial for us in emergency medicine to recognize this quickly?
Yeah, so blast crisis is defined as a rapid increase in our immature white blood cells, the blasts, above 20% in the blood or in the bone marrow, and the presence of extramedullary blast proliferation. So blast crisis typically occurs in CML, but it can occur in other myeloproliferative neoplasms and myelodysplastic syndromes, and is considered an oncological emergency. Patients really present very sick. They can have complications due to pancytopenias, leukostasis, or hyperviscosity syndromes. And that's why we should really care, because if it's left untreated, the median survival is only 3 to 6 months.
Yeah, so definitely a sobering statistic, and it underscores why early recognition is critical here. Now, you briefly touched on risk factors earlier, but could you dive a bit deeper into who exactly is at higher risk for developing blast crisis?
So it's patients with leukemia, specifically CML, and CML accounts for 15 to 20% of adult leukemias. Typically, most patients remain in that chronic phase. However, 10% of patients can progress to blast crisis, and this is despite treatment. And specific risk factors are patients who are refractory to the main treatment for CML, which is tyrosine kinase inhibitors like imatinib. But patients with specific chromosomal abnormalities in their Philadelphia positive leukemias can also develop blast crisis. Patients with high white blood cell counts, typically above the range of 100,000, can lead to leukostasis as well.
Okay, now let's talk about symptoms. When a patient with blast crisis walks into your ED, what does that typically look like, and what symptoms and signs should immediately catch your attention?
So their symptoms are typically due to the pancytopenia that they get from the blast crisis. As the blast cells take over the medullary space, you end up with anemia, neutropenia, and thrombocytopenia. So with the anemia, you can get fatigue, you can get malaise. With neutropenia, and this means functional neutropenia, their white blood cell counts may be very elevated, but because of the functional neutropenia, these patients are at very high risk for sepsis. And with thrombocytopenia, you can get bleeding and bruising. So as your blast cells increase, as your white blood cell count increase, you can also get leukostasis and hyperviscosity syndromes. So we think of these in terms of systems. In neurologic wise, you can get stroke-like symptoms, you can get visual changes, confusion. You can have cardiopulmonary manifestations as well, including ARDS and MIs, or any sort of acute cardiac injuries. You can have other organ system damage as well, including priapism, limb ischemia, bowel infarctions, and rapid deterioration is very common in blast crisis. So early recognition really is key here.
Now let's move on to diagnostics here. When you're suspicious of blast crisis, what labs are you ordering on these patients?
Well, the good news is a lot of the labs that we're ordering for these patients, we may be ordering for almost all of our other patients. So things like a CBC, specifically with a differential, we're looking for the blast count here to be above 20%, as well as profound cytopenias that we talked about. We're looking at the peripheral smear and the manual differential. We're looking to see the blasts as well as possible leukostasis. We're looking at the CMP, and we're specifically looking at lab markers that may signify tumor lysis, things like elevated potassium, low calcium. We're also sending uric acid levels, phosphate levels to look for those manifestations of tumor lysis syndrome. We're going to be sending our coagulation studies, PT, PTT, in order to look for signs of DIC. We're also sending LDH and uric acid specifically as markers for high cell turnover. And really the confirmatory test, which usually isn't done in the ED, is a bone marrow biopsy or flow cytometry.
Now, Sadakat, say we're pretty sure we're dealing with blast crisis in a patient. What should our initial management approach be in the ED?
Well, we always go back to what we learn, which is resuscitation, ABCs, supportive care. So that includes things like oxygen, IV fluids, monitoring vitals very closely. And we want to avoid aggressive resuscitation with packed RBCs in this case, because these patients are already at very high risk for hyperviscosity. So you want to be judicious with the products that you're giving to these patients, including for anemia and thrombocytopenia. One of the main things with blast crisis, as I said before, these patients are functionally neutropenic, so have a very, very, very low threshold to give them broad spectrum antibiotics immediately. And consider antifungals if they have prolonged febrile neutropenia. The main thing that you want to do for these patients is you want to get your hematologist, your oncologist on board as soon as possible, because a lot of these patients end up needing cytoreduction, with specifically leukophoresis for severe leukostasis symptoms. They may also require hydroxyurea in order to rapidly lower the white blood cell count. And a lot of these patients require high-dose chemotherapy, specifically the tyrosine kinase inhibitors. They may also require mutation testing for drug selection. So you'll really lean on your hematologists and oncologists here.
And beyond ED management, tell us about the prognosis.
So without treatment, the median survival is very low. It's 3 months. However, with the proper treatment, which includes the chemotherapy and potential stem cell transplant, survival can extend to over a year, and best outcomes are seen in patients who achieve a second chronic phase and undergo allogenic stem cell transplant.
Now, I want to pivot a little bit and talk about something that won't be side by side with this in our textbooks, but is still something that is important. And with these complex situations, I think it goes without saying that ethical dilemmas are going to be interwoven a lot of the time. So let's explore that and some of the tough decisions that providers encounter in these situations and talk about those considerations. And if you could, touch on some of the strategies for navigating them effectively.
Of course. Well, one of the things to remember here, as with all of medicine, is we're responsible for a balancing act in terms of what will treat the patient and what is right for the patient. Especially as ER physicians, we encounter this a lot in our practice. And one of the main things with blast crisis specifically is treatments can be very aggressive. It's very high dose chemotherapy. You're giving them products, leukoreduction, all sorts of things. And while they may offer a chance for remission, there are significant risks and side effects associated with these therapies. So deciding what's important for our patient, getting informed consent and leaning on patient autonomy is very important here, because a patient's beliefs, their goals may be different from what your goals are. And these therapies are not available everywhere. There's also a question of resource allocation here, as not all sites may have a hematologist or oncologist. Sometimes you may have to transfer these patients to a different site that may be hundreds of miles away. So these are all very important things to consider, as these resources are very high cost, limited availability, and we want to make sure that we have these conversations with our patients before we initiate all of this therapy. These dilemmas require a nuanced approach that balances medical evidence as well as ethical principles to provide the best care for our patients.
Yes, very well put. Okay, so we covered a lot today, a lot of high-yield stuff. I'm going to ask a very difficult task of you, which is to distill it down even further to some take-home points that you want our listeners to absorb and to keep in their vault.
So if I had to sum it up in 3 key take-home points, it would be 1, recognize blast crisis early. Look for things like pancytopenia, leukostasis, and rapid deterioration. 2, resuscitate and stabilize. Don't forget to give the antibiotics as indicated if you suspect infection. And don't be aggressive with your transfusions because these patients may be hyperviscous. And then 3, and probably most important, get your hematologist and oncologist involved as early as possible to start the definitive therapy, which is cytoreduction and chemotherapy.
Perfect, Sadakat. And again, thanks for being back in the studio with us.
Always a pleasure, Brian.